Okay, dear friends and colleagues, I'm very happy to open the second day of our International Conference of Thoracic Oncology. This is the second day, so the Immuno Day. We'll talk about all the possibilities to use immuno agents in non-small cell lung cancer, small cell lung cancer, and pleural mesothelioma. We have four sessions. The first for metastatic disease, the second chaired by Marina Garassino about the strategies to overcome resistance to checkpoint inhibitors with Suresh Ramalingam and Fabrice Barlesi. The third session, the early and local regional disease, chaired by Lucio Crinò, because Lorenzo Spaggiari sadly is not available for his role, with Sirish Gagil and Luis Pazzares as speaker, and the last session on the small cell lung cancer and pleural mesothelioma, chaired by Lucio, with Seven Liu and Paul Bass as speakers. So the day is full, and I think that it's better that I start my session. I'll share this important session about the metastatic disease to be treated with immuno agent with three very important speakers. Roy Herbst from Yale University, talking about the single agent in first and second line. Shiris Gagil from Henry Ford Cancer Institute and Ann Arbor, talking about the combination of immunotherapy and chemotherapy. And the third speaker, Martin Reck from Grosshansford, Germany, talking about combination of immuno agent, and chemotherapy. So three topics very to be updated, I think, and to be discussed. And then we have at the end of the presentation, we have near half hour to discuss together as usual in our conference. So I am very honored to introduce Professor Roy Herbst with his presentation, single agent in first and second line. Please, Roy.
Thank you for having me here. I'm here in New Haven, Connecticut, and it's my pleasure to talk about single agent immunotherapy in front and second line non-small cell lung cancer. We certainly have made great progress in the treatment of metastatic lung cancer since the late 1990s. Back then, we had only platinum and paclitaxel, gemcitabine, docetaxel, and you can see the survival curves with very little long-term benefit. 1 year survival was 33%, median survival was 7.9%. At 2 years, almost no one was alive. All platinum chemotherapy improved survival just by a little bit. All doublets were similar, and it was clear that a new paradigm was needed. Well, immunotherapy certainly fits that bill. Here at Yale, where I've been for the last decade, we're fortunate to have been one of the first sites to do a phase 1 trial with MDX-1106, now known as nivolumab. This is a patient of Dr. Scott Gettinger, my colleague here at the Yale Cancer Center. And you can see this patient with 3 times refractory squamous lung cancer with massive disease in her lung, liver, mediastinum, with a near complete response or complete response at 2 years. That actually occurred much sooner, and she remains that way 11 years later. The good news is that we see this on a reasonable basis. Bad news is it's only about 10% of the patients. Here's the data from that trial as a whole, the 5-year survival data for the Checkmate 3 trial led by Scott Gettinger and colleagues. And you can see that at 5 years, the actuarial survival is 16%. So 16% of patients do incredibly well, and the rest we have to continue to think about what else do we need to use and how to combine. But what we talk about is the tail of this curve, patients living for a long period of time. We know that biomarkers are important. This is a slide from David Rim at Yale showing two different areas of a piece of lung cancer tissue, one quite negative for PD-L1 with two different antibodies, one positive to different extents. We now know that PD-L1 is present either in the tumor cells, shown here with the green cytokeratin, and the stroma, shown here with the blue nuclei DAPI stain. So where do we measure it? How do we measure it? The heterogeneity makes it a complex biomarker. But I would contest that PD-L1 as a biomarker certainly is the best biomarker we have right now. Let me show you some data to prove that. So here's the KEYNOTE 10 trial, a trial that I was fortunate to lead as a steering committee chair. And we just published in JTO last week the 5-year survival. This was a trial of pembrolizumab versus docetaxel in previously treated PD-L1 advanced non-small cell lung cancer. As many of you recall, this trial was refractory patients, greater than 1 prior therapy, no active autoimmune disease. PD-L1 was measured and had to be more than 1%. And of course, we had a quantitation on it. And patients were randomized to either pembrolizumab, 10 milligram per kilogram for 35 cycles, pembrolizumab at 2 milligram per kilogram for 35 cycles, or docetaxel at 75 milligram per meter squared, the standard dose. Maintenance pembrolizumab was used, and there was a crossover for those patients in the control arm. You can see the results of the trial. These are the baseline characteristics. Patients who received pembrolizumab versus chemotherapy. It was a 2-to-1 randomization. There were no major differences in the group. We just recently presented those patients who had 35 cycles or 2 years of pembrolizumab. You can see that that group doesn't look much different than the other groups. And then the second course of pembrolizumab, 21 patients after they progressed, after stopping pembrolizumab, received pembrolizumab again. And I'll show you those data in a moment. But first, the data. The overall survival data for the entire population, the greater than 1% PD-L1, almost exactly the same as we saw with nivolumab, 15.6% at 5 years, 6.5% in the control. Of course, the control group, docetaxel, reflecting the crossover. If you look at the PD-L1 greater than 50% group, 25% survival at 5 years. Look at that in refractory non-small cell lung cancer. Absolutely amazing, and 8.2% in the patients in the control group, again, because of crossover. So really impressive results. If you look at progression-free survival, it is clear, however, that patients continue to progress. Even in those patients who got a PD-L1 with greater than 50%, you can see that the median PFS is 5.3 versus 4.2 months. And you can see that here. And in the group that's greater than 1%, the median PFS 4.0 versus 4.1. So there are many patients that would still benefit from combinations. And you're going to hear about from the other speakers, getting over this piece of the curve to get them to the tail. Here you can see overall response and duration of response. Here you can see for the 50% PD-L1 or the greater than 1% PD-L1, you can see the pembrolizumab, the response rate was 33% in the high group versus 9.2 for the docetaxel, 21.2% in the greater than 1% group, docetaxel not changed. Time to response was the same for all groups. Duration of response, this is the tail that I was talking about, 68.4 months in the 50%, 68.4 months in the 1%. Here you can see the objective response rate. Patients who completed 35 cycles, there were 79 of those in the trial. Of those patients, 78 had a response, 98.7%. There were 15 or 19% complete responses, 79.7% partial responses. One patient had a stable disease. The 3-year overall survival rate for completion of 35 cycles or 2 years was 83%. Here you can see, and this is published in the JTO, you can see those patients who actually progressed and then had a second course of pembrolizumab. You can see the end of the course shown here, 35 cycles. You can see when they progressed, and then shown here, and then you can see when they went on to the second line therapy. Of 21 patients, 11 who were retreated had a response for 52.4%. 4.8% of those were a complete response, 47.6% were a partial response, and incredibly 28.6% had stable disease. So you can see that most patients do have disease control on retreatment, an important fact. So to summarize, as I just showed you, very significant results for pembrolizumab at 5 years, maintained from the 3-year and the 2-year data that had previously been presented. And for those patients who complete 35 cycles, they had durable responses. And for those that progressed, they could be retreated. The toxicity assessment showed nothing new from what had been described in the past, manageable toxicity. I just want to say that pembrolizumab works in the brain and point out this study, a single agent investigator-initiated study from Yale, led by Harriet Kluger, Sarah Goldberg, and Veronica Chang. Patients with small brain mets here had to be less than 2 centimeters, treated with pembrolizumab, and you can see the tumors respond. This is looking at this trial of lung cancer or melanoma patients. These are the lung patients shown here. And you can see patients who responded in the brain in yellow also had their response extracerebral green. They tended to run together. So those studies led to CIOT 24. CIOT 24 is a very important study. It's a frontline study using PD-L1. So patients with untreated stage 4 non-small cell lung cancer, PD-L1 greater than 50%, performance status 0 to 1, no activating EGFR ALK or translocations, no untreated brain metastases. This trial was still lagging behind adding in brain metastases in, no active autoimmune disease, patients randomized to pembrolizumab, 200 milligrams IV Q3 weeks, or a platinum doublet, histologically appropriate, and then crossover, 67+% crossed over to pembrolizumab. Pembrolizumab was maintained here for 2 years. Here you can see the results, which are absolutely extraordinary. Up top, you can see the 5-year overall survival, 31.9% in untreated metastatic disease, 16.3% in the control. Again, because of crossover, hazard ratio 0.62. PFS, which is at 3 years, you can see the PFS, 22.8% in the high group, 50% progression-free versus only 4.1% in the control. This, of course, does not show any crossover, but still, why are 80% almost progressing? We still need to think about resistance, primary and acquired. Partial response rate, 41.6%. Again, not 100%, so there is some primary resistance. Here's CIOT 24. I just want to compare it to CIOT 189. And these are the patients in the CIOT 189 at 3 years who actually got chemotherapy plus immunotherapy, here immunotherapy alone. These data still look a little bit better, but there are many censored patients. So we're going to still have to wait to see whether CIOT 189 a chemo approach is better than just immunotherapy alone. In my practice, I use immunotherapy alone in the PD-L1 greater than 50% patients, unless there's really a desperate need for a quick response. Here's the Empower 110 study, published in the New England Journal last year, a study that I led the steering committee for with a multinational group, chemotherapy naive patients with non-squamous or squamous non-small cell lung cancer, received atezolizumab at 1,200 milligrams every 2 weeks, or histologically compatible chemotherapy, either maintained atezolizumab or this group received pemetrexed or best supportive care. There was no crossover in this trial, at least on study. Then, of course, and this study was positive for atezolizumab with a hazard ratio of 0.7 or so. Here's CIOT 42, 3-year survival update. This was presented recently at one of the major meetings. CIOT 42, pembrolizumab versus carboplatin paclitaxel in patients greater than 1% PD-L1. And in this study, we saw that most of the benefit tended to be in the patients in the 50% group, where the hazard ratio was 0.68. In the greater than 20% group, this was 0.75. And in the greater than 1% group, it was 0.80. And with subsequent review, it did appear that most of the benefit was in the 50% group. However, when the results were looked at in the 1 to 49% group, what you can see is that there wasn't that much difference as shown here. Hazard ratio is still 0.9, favoring the pembrolizumab, shown here in blue, but with minimal difference. And here you can see overall response, duration of response, and overall survival. And you can see here with the pembrolizumab as shown. So to conclude, in Keynote 42, it looked like the 1% cutoff it did result in the approval of pembrolizumab. However, most of the benefits still being in the greater than 50% patients. So now what's available in the first line setting? There are 3 approved agents, squamous versus non-squamous as single agent. There's pembrolizumab, atezolizumab, and cemiplimab. Pembrolizumab for greater than 1% PD-L1, atezo and cemiplimab for the high group, atezo for TC3, IC3, pretty much equivalent to PD-L1, 50%, cemiplimab in the 50% PD-L1 group. Now, this is going to be very important as we go forward. You know, do we use a combination in the 1%, or do we use pembrolizumab alone or IO alone? This trial called Insignia, a randomized phase 3 study of first-line immunotherapy alone or in combination with chemotherapy in induction, maintenance, or post-progression and advanced non-squamous non-small cell lung cancer with immunobiomarker signature-driven analysis. Quite a mouthful. This trial is ongoing through the cooperative groups in the US, SWOG and ECOG, and Chang and Haas-Borgai. Anyone who's greater than 1% PD-L1 can be randomized to either pembrolizumab, followed by carboplatin pemetrexed. So trying to figure out what to do second line, pembrolizumab, followed by carboplatin pemetrexed, pembrolizumab second line, or the triplet combination, the Keynote 189, carbo pemetrexed pembrolizumab, followed by pemetrexed pembrolizumab, and then the second line treatment is dealer's choice. This trial is accruing quite well and will be a very important treatment study. So here is a schema. This just came out today in Nature Medicine with Dr. Grant and Goldberg as authors from Yale, looking at the different groups and the choices one would make for treatment. If someone's PD-L1 high, if they're squamous or non-squamous, they can get pembrolizumab or atezolizumab, certainly cemiplimab now as well. And then you can see different options for these patients. In the low group, combinations usually with chemotherapy. In the negative group, combinations with chemotherapy or doublets. You'll hear more about this from other speakers. So with that, I'll thank you very much.
Thank you, Roy, for your presentation that I see that caused already many questions that I'll show you in the discussion time after the second, third speaker. So it's my honor to present Sirish Gagil with his topic, combination of immunotherapy plus chemotherapy plus or minus bevacizumab. Please, Sirish.
I apologize, did not unmute myself. First of all, thank you very much to Dr. DeMarinis, to Rosella and all the team members for inviting me for this symposium. Would have liked to be in Milan, but this is the best we can do with the pandemic. Hopefully next year we'll be all together. My task today is to discuss chemotherapy and immunotherapy with discussion about anti-VEGF therapy. I have listed my conflicts here. So to start off with, I wanted to discuss why should we combine chemotherapy with immunotherapy? It is not just a matter of adding immunotherapy to a previous standard of platinum-based chemotherapy, but chemotherapy can, and may be surprising to especially non-lung cancer doctors, or non-cancer doctors, that chemotherapy can have positive impact with regards to immune response against cancer. So first of all, immunotherapy does lead to release of neoantigens that can, through cytotoxic death, that can activate and increase the presence of CD8 T cells in the tumor microenvironment. And in addition, release cytosolic DNA, which then activates the STING pathway, which activates natural killer cells. In addition, it has a positive impact in terms of immune suppressive cells, such as reducing the number of regulatory T cells, as well as myeloid-derived stem cells. So these cells that are have a negative impact with regards to immune response can be impacted by cytotoxic chemotherapy. Now, this impact does vary based on which agent you look at. Now, this is preclinical data, and I must mention primarily led by investigators from Eli Lilly. But in their preclinical analysis, they found that pemetrexed had a positive impact in terms of the tumor microenvironment in inducing what one would consider a T cell inflamed phenotype, that is increasing the CD8 T cells and minimizing the regulatory T cells. And it appeared in their studies that there may be a difference based on what particular cytotoxic agents we are utilizing, in that pemetrexed appeared to be better at this in terms of inducing the T cell inflamed response compared to platinum or taxane. Now, how relevant this is in the clinical setting is absolutely unclear, but I think there is a point to make that chemotherapy can have a positive impact in regards to immune response against the cancer. And so there is a scientific rationale of combining chemotherapy with immunotherapy. One of the first randomized studies to evaluate addition of immunotherapy to chemotherapy was the KEYNOTE 21G trial. This was an extension of the KEYNOTE 21 phase 1 trial. And in this study, patients with advanced stage non-squamous non-small cell lung cancer were randomized to chemotherapy plus pembrolizumab or chemotherapy alone, with a planned crossover in the chemotherapy alone arm to pembrolizumab. Dr. Awad updated the results in JTO last year, and these updated results showed that there was improvement both in progression-free survival as well as overall survival, with a hazard ratio of 0.71 that translated into a median survival of 34 months versus 21 months with chemotherapy alone. These results, 21G, were the basis for KEYNOTE 189. That was a large phase 3 study that randomized patients with non-squamous non-small cell lung cancer that were whose tumors were negative for EGFR or ALK alteration. The stratification factors were according to PD-L1 expression, the platinum used, and the smoking status. And the patients were randomized to, again, chemotherapy plus pembrolizumab or chemotherapy plus placebo. So this was a placebo-controlled randomized study with a planned crossover to pemetrexed in patients who were on placebo and at the time of disease progression. It's important to note that patients who received chemotherapy plus pembrolizumab continued on maintenance or were allowed to continue on pemetrexed and pembrolizumab, with the pembrolizumab being given for a total of 2 years, and pemetrexed could be continued beyond that as per investigators' decision. The reason I'm mentioning this is that at least in the US, it has been noticed that many physicians terminate pemetrexed also after 4 cycles. And it's important to note that in 189, both agents were continued as maintenance therapy. Of course, one does not know what the relevance of the combination is in terms of in the maintenance setting. Nonetheless, it's important to stick with the way the study was designed. These are the updated results showing a survival advantage with the addition of pembrolizumab, with a hazard ratio of 0.56 that translated into a median survival of 22 months with the combination, and an absolute 16% improvement in survival with the addition of pembrolizumab at 2 years. And the benefit was seen across all PD-L1 subsets. So the hazard ratio was 0.59 in PD-L1 high expressors, 0.62 in PD-L1 1 to 49. And even in PD-L1 low, the hazard ratio was 0.52, suggesting that the addition of pembrolizumab to chemotherapy does appear to have at least an additive effect, since, as it's well recognized, immunotherapy alone is not that effective in PD-L1 low negative patients. Now, the combination is associated with some greater toxicity, and that did have clinical consequence in that, almost a third of the patients stopped at least one component in the experimental arm, one component of the treatment in the experimental arm because of adverse events. So it's important to recognize that 1/3 of the patients did have discontinuation of one of the agents. The toxicities, though, were primarily what one would expect related to the cytotoxic chemotherapy and related to immunotherapy, with no evidence that the addition of immunotherapy to chemotherapy necessarily leads to any increased incidence of either immune-related events or cytotoxic chemotherapy related adverse events. One exception to that is an increased rate of renal events. So acute kidney injury was observed in about 5% of the patients with this particular combination, as compared to 0.5% with platinum pemetrexate. And I can tell you in my personal experience, this can happen even late, that is even after 1 to 1.5 years. And it is for this reason that sometimes, depending upon the patient, I will skip IV contrast in these patients and do everything I can when I'm ordering scans and do everything I can to minimize exposure to nephrotoxic agents, in particular in patients who have been on this therapy for a long period of time. So that brings up to the sort of the companion study, if I may, which is CIOT 407, that evaluated chemotherapy plus pembrolizumab in squamous cell patients. Very similar design, of course, no necessary for testing of EGFR or ALK, since these were squamous cell patients. Maintenance pembrolizumab, and in the combination arm, in the chemotherapy arm, continuation of placebo. Again, there was a planned crossover, or at least the potential for crossover in the placebo arm. These results are from an updated analysis by Dr. Paz-Ares, and this showed that there was a survival advantage with a hazard ratio of 0.71. The median survival was 17 months with the addition of pembrolizumab, and this translated in about an 8% improvement rather 7% improvement in overall survival with the addition of pembrolizumab at 2 years. Now, the benefit, again, in this study was seen both in patients with PD-L1 positive as well as in PD-L1 negative, but it is quite clear that the benefit does appear to be less in PD-L1 negative, and I'll come to this issue a little later. So this brings up the point, and Dr. Herbst touched on this, as to how do we sort of decide the best treatment for our patients who do not have a driver genetic alterations, utilizing the PD-L1 marker. And so if you look at the efficacy of 24, 42, 189, and 407 in PD-L1 high patients, they appear relatively similar, though the response rate is clearly higher, and response rate is not mentioned with the addition of chemotherapy. And as Dr. Herbst said, and this is a quotation from Dr. Bunn, Dr. Paul Bunn, that usually in PD-L1 high patients, consideration is made of using chemotherapy plus immunotherapy in patients where there's a desire to have a quick response. Otherwise, there's preference to use single agent immunotherapy. What about the patients who are PD-L1 negative? This was a combined analysis of 21G, 189, and 407 presented by Dr. Garasino at World Lung in 2019. And they showed that in this population, in a combined pooled analysis, there was clearly a benefit with a hazard ratio of 0.56. However, it is quite clear that that benefit, when you look at the forest plots, is much more in non-squamous patients as compared to squamous. It is not clear what the specific reason is. Is it because patients in the non-squamous population got pemetrexate, both in the induction as well as in maintenance study setting, whereas taxanes were used in squamous cell and there was no maintenance therapy, is unclear. Nonetheless, there appears to be an indication that the combination of chemotherapy and IO in the PD-L1 negative appears to provide a little bit better benefit in non-squamous as compared to squamous. And without stealing the great presentation that Dr. Martin Reck is going to do, I thought that this data that he presented at ASCO this year from Checkmate 9LA provides a perspective with regards to the PD-L1 negative patients. In this study, as you know, 2 cycles of chemotherapy were combined with Nivo and ipilimumab. And this showed a survival advantage with a hazard ratio of 0.67 in PD-L1 negative. But what was, I felt quite remarkable, that the benefit was opposite of what was seen in the combined chemo IO analysis. Here, the benefit was greater in squamous cell patients. And interestingly, this is consistent with what was observed in Checkmate 227, raising the possibility that in PD-L1 negative patients, particularly squamous patients, it is possible that the Nivo-Ipi combination with or without chemotherapy may offer a better survival outcome. At ASCO this year, another group that was evaluated was the 1 to 49 PD-L1 group. Though at least in the US, there's approval for pembrolizumab in this group, pembrolizumab is not commonly used for this patient population. The FDA, the US FDA, presented analysis of studies that led to the approval of agents. This included the CIOT studies that evaluated single agent pembrolizumab, also included Checkmate 227, and then the chemo IO studies, including Checkmate 9LA. And what they showed is in the PD-L1 1 to 49, chemo plus IO provided better survival as compared to immunotherapy alone, whether it was single agent IO or combination IO. However, this benefit was not clear in patients above the age of 75, partly because the numbers were lower. Though the trend was towards chemo IO being better, it was not statistically significant. And again, the benefit was also not that clear in never smokers. So what this suggests is that at least in the group 1 to 49, there's a greater advantage to chemo IO compared to immunotherapy alone. Another biomarker that has been evaluated is the tumor mutational burden. This is data that Dr. Herbst presented at ESMO in 2019. This was data from Keynote 42. And what was seen is that even in the PD-L1 positive patients, that high TMB predicted for a survival advantage with single agent pembro as compared to patients with low TMB. So TMB, even if PD-L1 selection has been made of single agent immunotherapy based on PD-L1, may provide further differentiation of which patients are going to derive benefit. This was mainly to provide a perspective. When you look at the same data in terms of chemo IO, both in Keynote 189 as well as in Keynote 407, there did not appear to be a differentiation of efficacy of chemo IO with regards to TMB. That is, the benefit was very similar in patients with tumors that are high TMB versus low TMB. This is 189 data, and this is 407 data, both presented by Dr. Paz-Ares at World Lung in 2019. So TMB may not be predictive for benefit from chemo IO. Another biomarker that has emerged as predicting for lack of benefit with chemo IO are STK11 mutations at KIP1, which occur in about 20% of adenocarcinomas. And so a retrospective subset analysis was conducted of the Keynote 189 study. Mind you, only about half the patients were who had tumors sufficient to be tested with whole exome sequencing. And what this showed is that the benefit was clearly lower when it came to overall survival in the mutated STK11 mutated patients as compared to wild type, though there was improvement in overall survival with the addition of pembrolizumab to chemotherapy, both in the KIP1 mutated as well as STK11 mutated, suggesting that yes, these patients may have less of a benefit than the wild type patients. But nonetheless, the trend is better with the addition of immunotherapy to chemotherapy as compared to chemotherapy alone, again demonstrated also by the response rates. Moving on to now, how do we move forward? Chemo IO has become more or less the default upfront regimen in patients with driver-negative advanced non-small cell lung cancer. And one of the agents that has definitely gained attraction are anti-VEGF agents, since already there is a track record of these agents in treatment of non-small cell lung cancer. However, angiogenesis and tumor response do overlap. And so increased production of VEGF does have a negative impact on immune response against cancers, with reduction in CD8 T cells, increase in tumor-associated macrophages, as well as tumor T regulatory cells. And interestingly, inflammatory cytokines released by in the tumor microenvironment can have pro-angiogenic and anti-angiogenic effect, in that the immune suppressive cells appear to enhance tumor and angiogenesis. And so there's clearly a rationale to combine anti-VEGF agents or anti-angiogenic agents with immune response. And this has already been done in Empower 150. As we know, this did show the addition of bevacizumab to atezolizumab, addition of atezolizumab to bevacizumab, carboplatin, paclitaxel, improved survival. And interestingly, there was improved survival also observed in EGFR mutation positive patients, which we know historically have not as much benefited, at least from single agent IO treatment. There are several other anti-VEGF agents that are being now evaluated, lenvatinib being one of them. This is data from a phase 1 study that evaluated this combination in a variety of tumor types and found promising response rates with the combination. And based on this, there are several ongoing large randomized phase 3 studies. LEAP 006 study is evaluating lenvatinib plus chemotherapy with the Keynote 189 regimen. It remains to be seen whether the addition of this agent will improve upon the Keynote 189 results. I will admit I have some concerns about tolerability, though apparently the initial results have not raised any concerns about tolerability. I wanted to finish up. There are several other agents that are being now evaluated to improve upon the chemo IO, one being tiragolumab and anti-TIGIT. There are several other agents. And what this is data of the combination of atezolizumab and tiragolumab, not with chemotherapy. This is PD-L1 high patients that showed an advantage with the combination. And similar to what was observed with the addition of pembrolizumab to chemotherapy, it is possible that the addition of an anti-TIGIT with anti-PD-1 or PD-L1 and chemotherapy may improve efficacy across all PD-L1 subsets, but the studies are ongoing. So in conclusion, chemotherapy and immunotherapy has become the standard therapy for most patients with driver-negative advanced non-small cell lung cancer. Benefit is observed across PD-L1 subsets, as well as tumor mutational burden. Benefit appears less in STK11 and KIP1 mutated patients, but the trend is for improved outcomes compared to chemotherapy alone. And there are several combinations being evaluated, specifically anti-VEGF and anti-TIGIT. Thank you very much.
Thank you, Shirish, for your very complete presentation. Also for you, the question to the end of the three speakers. So for the last presentation, I have the pleasure to introduce Martin Reck, a very expert in immunotherapy in lung cancer. And I'm very happy for his coming to the CIOT. Please, Martin, with your presentation about combo of immuno, and chemo agents, please.
Thank you, Filippo, for the kind introduction, for the invitation. Can you hear me? It's okay?
Perfect.
So it's my pleasure to talk to you to the third part of therapeutic opportunities that we do now have in first-line treatment for patients with advanced non-small cell lung cancer. We have heard the exciting results about the opportunity of monotherapy in the biomarker selected patients in the group of patients with PD-L1 expressing, or for us in Europe, more importantly, for the patients with high PD-L1 expressing tumors. Shirish has talked about the opportunity to combine chemotherapy with checkpoint inhibitors, and this has been done in numerous trials showing a consistent benefit in efficacy in overall survival. And now I will come to the third, I would say a little bit newer opportunity that we do have for our patient, and this is the combination of different checkpoint inhibitors with or without additional chemotherapy. Well, we have learned that our immune response is related or is balanced by numerous activating and inhibitory checkpoints. This is a very tightly balanced situation. And we have learned in the recent years that a tumor can use the system to suppress the quite natural immune reaction against the tumor. There are numerous checkpoint inhibitors, activating inhibitory checkpoint inhibitors on the market in clinical development. But interestingly, when we look on the treatment scenario of lung cancer, the majority of data so far, in particular, when we look on the majority of data in randomized trials, has been generated for the combination of anti-CTLA-4 antibodies and anti-PD-1 or anti-PD-L1 antibodies. And this makes sense. So the anti-CTLA-4 axis and the anti-PD-1, anti-PD-L1 axis are two completely different checkpoint inhibitors at checkpoint areas, which work in completely different activation periods of the tumor. Anti-CTLA-4 quite in the early period of T-cell priming, T-cell activation, and anti-PD-1, anti-PD-L1 quite late on already activated T-cells in the interaction with the tumor cells. So we can expect a complementary synergistic activity by combining this different type of checkpoint inhibitors. So one of the combination which has been investigated in randomized trials has been the combination of the anti-CTLA-4 antibody tremelimumab together with durvalumab and anti-PD-L1 antibody. And the first trial where we have seen data from has been the MYSTIC trial. This has been a free-arm trial in untreated patients with advanced non-small cell lung cancer, and the patients were randomized between a monotherapy with durvalumab, the combination of durvalumab and tremelimumab, or platinum-based chemotherapy as a control arm. And of note, this was a trial performed in a PD-L1 expressing population. All the patients had a PD-L1 expression of at least 25%. And we had 3 co-primary endpoints: progression-free survival for the immunotherapy combination, overall survival for the monotherapy, and overall survival for the immunotherapy combination, all against the control arm, which was chemotherapy. Formally, this was a negative trial because none of the arms or none of the endpoints reached statistical significance. However, we have seen a signal in overall survival, a trend in overall survival for the monotherapy of durvalumab compared to chemotherapy in this PD-L1 expressing population. For the combination of tremelimumab and durvalumab, we had the problem of crossing overall survival curves. So therefore, in this group of patients, we haven't seen any clinical relevant difference. Interestingly, when we look on the data of a retrospective analysis, there was a correlation of the efficacy endpoints to the tumor mutational burden assessed in the blood, which means blood-based tumor mutational burden. And this was seen for progression-free survival and overall survival. And there was a stepwise correlation with the efficacy related to the number of mutation, and the best signal of efficacy was seen in the group of patients or in the group of tumors with a threshold of at least 20 mutations per megabase. Well, this signal now was taken further into a prospective evaluation Another trial was designed, which was the Neptune trial, investigating the combination of durvalumab and tremelimumab against chemotherapy. And following these retrospective analysis, there was a change of the primary endpoint, looking on overall survival in the group of patients with high blood-based tumor mutational burden. We haven't seen the data so far. We only have seen a press release that the primary endpoint of prolongation of overall survival hasn't reached. And we also have another trial which hasn't been presented so far, which is the Poseidon trial. This is a trial looking on the combination of durvalumab and platinum-based chemotherapy, or durvalumab and tremelimumab and platinum-based chemotherapy compared to chemotherapy alone. So far, we have received 2 press releases. Number one was from October 2019, showing a significant benefit in progression-free survival for the experimental arm, for both experimental arms. And we have got a second press release from May this year, declaring that also a survival benefit has been shown for the combination of durvalumab and tremelimumab. However, we are still keen to see the data, in particular also the tolerability data, because the patients were assigned to receive a full dose platinum-based chemotherapy together with a combination of durvalumab and tremelimumab. Well, the other combination, which has been investigated in a couple of randomized trials, has been the combination of nivolumab and ipilimumab. And the first data set has been presented for the CheckMate 227, in principle investigating the combination of nivolumab and ipilimumab against platinum-based chemotherapy in 2 large cohorts, in a cohort of PD-L1 expressing tumors and in a cohort of PD-L1 negative tumors. There was one additional third exploratory arm in both of the cohorts, which investigated additional signals of efficacy. There were 2 co-primary endpoints. Number one was the progression-free survival in patients with high tumor mutational burden. This was positive. And the second co-primary endpoint was the overall survival in patients with PD-L1 expressing tumors. And this was also significantly improved in favor of the combination of ipilimumab and nivolumab compared to platinum-based chemotherapy. This year at ASCO, we had the 4-year overall survival update, and we did observe a consistent benefit in overall survival favoring the combination of ipilimumab and nivolumab against chemotherapy, with a 4-year survival rate of 29% compared to 18% in the control arm in the group of patients with PD-L1 expressing tumors. Interestingly, we have seen a comparable prolongation of overall survival also in the group of patients with PD-L1 negative tumors, which means that the signal of efficacy was completely independent from the PD-L1 expression in the CheckMate 227. And the other very interesting signal is when we look on the censored patient, that there are still a high number of censored patients on the right side of the 4-year landmark of overall survival, which means that we can expect further improvement of survival with further follow-ups. There was the question of the impact of side effects on the efficacy of the combination, and therefore we performed a retrospective post-hoc analysis on those patients who had to discontinue the immunotherapy combination and compared or looked on this data in the picture of those patients who were randomized within the intent to treat population. When we look on the overall survival data, the signal of overall survival was not impacted by the discontinuation of the agents. 3-year overall survival rate 48% compared to 33%, 4-year overall survival rate 44% compared to 29%. And also, when we look on the other efficacy parameter, they didn't seem to be affected by the discontinuation of the immunotherapy combination. The next step has been the CheckMate 9LA, combining the immunotherapy combination with 2 cycles of chemotherapy. And the basic hypothesis was to achieve early disease control on patients with a high tumor burden, with a with a fast-growing tumor. Primary endpoint was overall survival. Last year, we have seen that already in the interim analysis, there was a significant improvement in overall survival. This year, we presented the 2-year overall survival data. We have seen consistent signal in overall survival with a 2-year overall survival rate of 38% compared to 26%. Similar to the checkmate 2-7, we have a high number of censored patients. So these data are far away from mature survival data. We will need further follow-ups, in particular, to capture the effect of the anti-CTLA-4 antibody, the ipilimumab. This is a view on the difference between the checkmate 2-7 and the checkmate 9LA. And you can see here with the early chemotherapy that there has been a separation of the Kaplan-Meier curves from the first day of treatment. The benefit was seen mostly across all subgroups which have been investigated. There have been 2 subgroups with a limited effects. These have been the subgroups of patients older than 75 years and the group of patients who were never smokers. This is a signal that we do see also in other immunotherapy trials. On the other hand, we have seen quite an encouraging signal in patients with pre-treated brain metastasis. The efficacy was independent from the histology of the tumor, and this has been one of the stratification factors. We also looked on the impact of tumor mutational burden on the efficacy of this combination and progression-free survival. There was a slight trend in a pronounced efficacy in patients with a high tissue-based tumor mutational burden. However, when we look on overall survival, the efficacy or the impact on overall survival was completely independent from the burden of mutations. And this also was seen across various levels of tissue-based tumor mutational burden or blood-based tumor mutational burden. Even when we tried to combine the PD-L1 expression and the tumor mutational burden, we couldn't find any significant correlation to efficacy for one of these expression or mutation levels. Looking on the PD-L1 expression, like Shiraz Rachid pointed out, the efficacy in the checkmate 9LA was completely independent from the PD-L1 expression level. It was seen across all investigated PD-L1 expression levels, and this was again the second stratification factor. And there was this quite interesting signal in the group of patients with PD-L1 negative tumors and a hazard ratio of 0.48 in the group of patients with squamous cell non-small cell lung cancer. However, we have to be a bit cautious. This has been an exploratory analysis. It's a second subgroup analysis. The number of patients is limited. So this might be something real, but I think we need some more prospective data for this question. Again, we also looked on the group of patients who had to discontinue all compounds of the combination due to toxicity. And we compared this to the intent to treat population. And again, there was no impact on the efficacy when we looked on overall survival. The 2-year survival rate was 54% in the discontinuation population and 38% in the intent to treat population. And also when we look on response, we had a response rate of 51% and more than 50% had an ongoing response for at least 1 year after the discontinuation of the treatment compounds. So the big question, and I think this is one of the questions for the discussion, is how to select the appropriate treatment for the individual patient when we select our first-line opportunity. I do not have a clear recommendation, but there are some arguments, I would say, just to consider the checkmate 9LA. So we have seen the efficacy across all PD-L1 levels, including the PD-L1 negative tumors. We have seen the efficacy across all histologies, including also squamous cell non-small cell lung cancer. We have seen the early efficacy with a low rate of primary progression. We have seen an interesting signal in patients with pre-treated brain metastasis, which requires further exploration. And we had the advantage of using only 2 cycles of chemotherapy. And this gives us some more opportunities when we think about the post-progression period, because currently we only have docetaxel plus or minus an anti-angiogenic agent in hand as a post-progression opportunity. After checkmate 9LA in the post-progression period, the majority of the patients who received the second-line therapy received a platinum-based combination, which is, I think, a good or at least a reasonable opportunity in this setting. Having said this, I would like to thank you for your kind attention, and I look forward to the discussion.
Many thanks, Martin, for your complete exposition. We go directly to the discussion time. Roy Herbst, unfortunately, is not more available for the discussion for an expected engagement, but I see on the screen that we have more than the speaker, some other dear friends. Hi, Paul.
Hi.
Hi, and Lucio Grino. Thank you for coming in this room for a very big discussion. So we have the connection in this moment. We have 100 colleagues connected. We have time. We have wish. We have topics, so we can start with the questions that I already received on the screen. So the first question is, the patients evaluated in Empower 110 trial with high expression of PD-L1 using Ventana SP 142 are the same that we diagnosed in real life using DACO 22C3? So this is a question for Roy, but the absent, I participated to the same study of Roy. I can answer that after the first presentation, all patients diagnosed initially with Ventana test were being retested using DACO 22C3 test, and we obtained the same results for atezolizumab versus chemotherapy, confirming that is not important the test, but the most part of the patients are the same, and the curves of survival are the same. Any friend than what?
I have a question, if I may. I like the presentations very much. Congratulations. Now, a bit of practical issue and a comment. We are often looking with these IO treatments to the median overall survival, but I think the real power is in the tail of the curves. And I always see a lot of patients who are still censored. So I would like to hear from the speakers what they think of it. Should we change the approach? That's one. And so the 4-year survival is very important. And the second is, do you think it's now already prime time for patients who have not a PD-L1 over 50% to start with chemotherapy, 2 courses, and IO?
Martin.
So I think this, I would say statistical consideration is very interesting. And I think we have now the first trials where we modified the statistical design. We looked on disproportionate hazard ratios. And I think this is extremely important to cover the late effect on the overall survival, not to concentrate the statistical power on the median overall survival. And I think we only have to work with the landmark analysis. We only can work with 2, 3, 4-year survival rates. I think this is quite unusual for us in non-small cell lung cancer. We didn't have this opportunity some years ago, but I think in general for the future, we have to respect this new signals that we are generating, in particular with the long-term benefit. And in particular, when we look on the combination of checkpoint inhibitors. So personally, I do not believe that we will see, for example, a substantial effect in progression-free survival or something like this. The effect will be in the late outcomes of the patients, and this has to be respected in the statistical design. Now, for the checkmate 9A, I would say, from the bottom line, this is a positive trial. So this is a treatment opportunity. We are using this in our patient, but you are completely right. It's not so easy to make a selection between, let's say, our conventional approach like the Keynote 189 schedule and to switch to this new opportunity. I think we are in a learning period. Personally, I do believe that, of course, this suggestive population of patients with PD-L1 negative tumor squamous cell histology might be a good starting point. Overall, we haven't seen a real differential sign or signal of efficacy in the different subgroups that we investigated. And personally, I'm really looking on the individual patients. So I really think we have to look on the comorbidity profiles. Shirish mentioned that there has been a signal of renal toxicity following the combination with pemetrexed in the maintenance part. And we know from our real life that a couple of our patients have comorbidities with renal insufficiencies. There, I would be quite cautious. On the other hand, if I have a patient with a GI comorbidity, I would not be very enthusiastic to use ipilimumab in this group of patients. So these are my current thoughts, but I think we are in the training part and it's a new opportunity that we have.
Okay, another question from the web. In our clinical practice, an important percentage of patients with PD-L1 more than 50% treated with pembrolizumab alone in first line die in the first 3-4 months. The same also for atezolizumab in Empower 110. So Roy is absent, but I remember that the curves are similar. So in the curve for atezo is better starting from the 4th month and until the 3rd, 4 months, the curve of chemo is better. Your idea, Martin? Are similar, well, so the curves are similar in both studies. The problem is the immuno agent alone.
Yeah. So it's clear we are losing some patients in the first part, and currently we do not have our, I would say, clear characteristics. Shirish had the statement of Paul Bunn saying that the patient who is in demand of a response should receive a combination even with a high PD-1 expression. Currently, this is our clinical way to manage this problem. I think we do not have a good translational picture of the tumors and the patient. And I think this is the only way how we can proceed. In principle, I do not see any substantial difference between the monotherapy arm of atezolizumab and the monotherapy arms of pembrolizumab.
Another question, please, Lucio. Microphone. Thanks.
I have a question exactly regarding the fast progressor during the first part of IO. This has been a question that has been afforded for some time in the past time, but I would like to ask to the speakers if there is a real problem of patients that do not respond in the early beginning of the treatment and they go quickly, very quickly in progression. And if this can be in some way limited by a more important induction treatment, combining IO and chemotherapy.
Because I want to explain to the other friends. So in Italy, it is impossible to combine chemo and the pembro for patients expressing PD-L1 more than 50%. It's not reimbursed. So we are unable to use for this class of patients the combination. And we see our patients suffering, our patients suffering for this impossibility to use a combination. Another question from the web, considering—
So perhaps, yeah,
please.
I think so. So the answer, I think Shirish had the first answer. He showed the response rate. And we have got a similar signal when we look on the progression-free survival rates and the curves between the combination trials and the monotherapy trials, in particular in this group of patients with high PD-1 expression. There's a difference in the shape of the curves favoring the combination with an early control of the disease. And I think this is translating also to a rapid control of the tumor. So I'm a big fan of the monotherapy, and I would like to give this as many patients as possible. But if there really is the need for a fast response, I ever would go for a combination. The other question is whether some upscaling would also be of benefit for the patient. And this is something which is, for example, not possible in Germany. So we have to decide for the first day whether we go with a combination or with the monotherapy. But for example, in the Empower-1 trial, in the cemiplimab trial, there was the opportunity that at time of progression, patients could switch from the monotherapy to the combination of cemiplimab and chemotherapy. And I would be very keen to see these results, because this would reflect something that I would do also in clinical practice if I had a patient who would progress after first-line therapy to escalate the therapy. And the other elephant in the room, I think, is always the question of this hyperprogression, whether this is something real that we do see in our patients, or whether this is something that we can manage with a combination therapy. Perhaps my colleagues can comment on this. This has been presented very strongly from our French colleagues.
Yeah.
And by Dr. Garasino about the hyperprogression. So the only thing I will add to what Martin said is that this is pure anecdotal evidence, but in patients with PD-L1 high tumors who have progressed on single agent pembrolizumab, I've essentially only used pembrolizumab in that group when I've used a single agent IO. In most of those patients who progress, particularly who progress early, I have actually continued the pembrolizumab and added chemotherapy, and have really seen good long-term outcome. Now, who knows, they might have had the same benefit with carboplatin pemetrexate, but it has been quite impressive as to how many patients, again, I'm not saying I have a big series, but about a handful of patients where I've done that. They've had good control over years in many of the cases. So I agree with Martin. It would be really nice to see, particularly in the PD-L1 high patients, as to the ones who progress, if continuation of pembrolizumab as opposed to switching to chemotherapy, that is continuation of pembrolizumab adding chemotherapy, provides any benefit.
There is a question, another question from the web. Considering the CIOT 189 trial, in the real life, is difficult to obtain the same results using the chemo and pembro. A possible explanation? So I don't see to Martin to answer, because I won't exclude Martin. I want to ask to Shirish to answer, because in the US there are many publications considering the difference from the academic center results and non-academic center results, and it's full of paper focusing on the difference from the registration trials and the real life. So your opinion, and after the opinion of Martin.
Absolutely. The efficacy is less. What I can tell you is a recent real world publication, the median survival was only about 14 months or so, whereas the median survival in CIOT 189 was 22 months. I think there are several factors. One is many folks don't recognize that none of these randomized trials included performance status 2 patients. These were performance status 0 and 1. And in real life, almost, I would say, a quarter or at least 20 to 25% of the patients, and I'm sure it varies, are performance status 2. And so one expects that these patients don't do as well as performance status 0 and 1. The other thing is you have to realize the study required tissue submission, required that the PD-L1 status could be assessed centrally. They did not reveal the PD-L1 status. But I can tell you that in real life, the ability to allow submission of tissue and then ensure and then wait to hear back from the sponsor that they have adequate tissue always selects a patient population that is going to do better. And so I'm really not surprised, and I'm sure there are a variety of other reasons, but I'm really not surprised that in real world, the benefits are less, because this is no doubt in the 189 study in which I had the privilege of participating. These were there were patients who were excluded because we couldn't afford to wait to start systemic therapy. And so you were waiting after the biopsy and making the decision at least for sometimes 2 to 3 weeks. And obviously that is not possible. So I really think that performance status 2 and the study related requirements make it quite likely that in the real world, this regimen does not provide the same benefit as was seen in 189.
I agree completely with you, Shirish, for the PS2 problem. Sharing some data with some opinion with my friend 3 weeks ago about this problem of PS2 patients and immunotherapy for this kind of patient. He said, no, but PS2 doesn't exist. Exists good performance status, but poor performance status, not the PS2. So I think this problem of PS2 is a very problem, and in 2 weeks with some other friends we discuss about Immuno and PS2, we organize a meeting, because I think that in the clinical practice the evaluation of these patients is very critical, and our data are not positive for these patients.
So I think I just can add, I completely agree with Shirish, and we measured the participation in clinical trials in our German patients. It's below 10% of our patients who are participating in clinical prospective clinical trials. So this is a highly selected population, and I'm not surprised that the efficacy data generated in reality are below the trial results. And this is something we also have seen in the KEYNOTE-24, because as Shirish mentioned, the patient had to wait a long time for getting the central confirmation of the PD-L1 expression status. And we also try to capture this real world data. So we have a German-wide registry where we look on the real world efficacy data in all this new treatment opportunities. So hopefully we will get some more information out of that. But coming back to this point, and this would be my question for Shirish, in the United States, you have the opportunity to use the monotherapy even for the PD-L1 positive patients. And this has been discussed after the KEYNOTE-42 outcomes, that this could be an opportunity also for PS2 patients who are unfit for chemotherapy, although we never have proven this in a prospective trial. So what is your way? How do you use this monotherapy in your institution, and how is your perception in the United States?
So generally, I have not used single agent pembrolizumab for PD-L1 less than 50%, even if their performance status is not good. There are a couple of concerns I have. One is that, as is mentioned, even in PD-L1 high, in the first part of the curve, there is a bit of a dip with the immunotherapy compared to chemotherapy, single agent immunotherapy compared to chemotherapy. And one suspects that those were patients that had more rapidly growing tumors, or were, let's say, on the higher end of PS1. And so I'm not certain that pembrolizumab necessarily would achieve clinical benefit in those patients in a sufficiently clinically relevant time to be meaningful. I can tell you pembrolizumab is used in that situation now more and more. Nivolumab, ipilimumab is used, even though there are concerns about the toxicity of the IO combination. But in general, I have not used. And in fact, I would say that with the FDA publication, FDA presentation at ASCO this year of 1 to 49, there are some folks who have raised concerns about the Insignia trial that Dr. Herbst Roy mentioned, which is a large cooperative group trial ongoing in the US, which is selecting patients, non-squamous patients that are PD-L1 positive, and they are randomized at least in one arm to pembrolizumab alone, and folks are wondering, based on all the data that is available, whether that's a legitimate arm. So yes, it is approved. I guess it is used in the US, but I don't think that even in the community practice, the use is that high, particularly if you look at the PS2 patients.
Paul, have you an idea about this?
Well, I think that PS2 is in the eye of the beholder. So it really depends on how the people come into my my office. And I know that most of them have had a boost in some way, that if you would follow them home, you would see that they have a much worse performance. So it's always difficult. And some people really ask for a treatment. And I try to also use the immunogram by Christian Blanc and John Hane to see if they have a high LDH, infectious parameters, how the neutrophil lymphocyte ratio is. And then I try to make a discussion with the patient, because withholding a treatment is also very difficult. And I must say that Pembro, I've given it a few times in the, let's say, less than 50, the 1 to 49%. And I was surprised in some cases it was doing pretty well. So I'm open for this to some extent.
So the PS2 scales were evaluated in the chemo era. It's possible that in the immuno era we can change this kind of evaluation and rechange this Karnofsky scale on ECOG scale, more appropriate for the chemo. Also, if want to evaluate the patients. Okay, another question from the web. In Italy, so I want to see you that I want to say you that in this moment we are more than 100 people connected. So in Italy, pembrolizumab alone is not reimbursed for patients with PD-L1 between 1 and 49%, and the chemo plus pembro is not reimbursed for those with PD-L1 more than 50%. What is worse for Italian patients? So Chirish answered before talking about the not using PD-L1 in less than 50% PD-L1 patients. Pembro in patients with PD-L1 less than 50%.
So first of all, having been to Italy now for 5 years, I can never say anything is wrong with Italy. So I want to start off by saying that. I will say that I have used chemo pembro in the PD-L1 high patients, as mentioned, when the patients have had extensive metastases, multiple liver mets, multiple bone mets. I have preferred to use chemo pembro. I really have not used pembro alone in the less than 50% in those. So if I had to make a choice, if this was like my choice, I would say that the one thing that I would miss compared to what I do here in US is the ability to use chemo pembro in the PD-L1 high patients in a select group of patient population.
Lucio,
Yeah.
what is worse for the Italian?
Well, I think that the worst is that we cannot use chemo and IO together in patients over 50% of expression of PD-L1, because there are some patients that probably need an induction treatment more aggressive. And I think that this is the most important limitation that we have today in starting the treatment of our patients.
I'm sure that this is the problem, and we hope in Italy that Checkmate 9LA will be reimbursed also for the part of patients expressing PD-L1 more than 50%. Because in my mind, it's impossible to separate the study and reimburse a part of the study. Or we accept all the study, all the results, or it's very crazy to divide the study in different results for different way of reimbursement. Or no, Martin?
So, yes, I think I agree with Lucio. This is, I think, perhaps a missed chance for our patients. I think, yes, we have seen the efficacy of the Checkmate 9LA regime also in the high expressors. I think we need a good reason to use the schedule in this group of patients. It's a regimen with a certain toxicity, and we have to reflect this when we apply this to our patients. It's certainly not a regimen for a PS2 patient. And I think this has to be taken into account. And I think the monitoring of the patient and the fast reaction to the side effects is key in the usage of this new schedule.
Good. Another question to Dr. Reck. Even if there are subgroup analysis 227 and 9LA, do you think that for squamous histology PD-L1 less than 1%, do you think ipilimumab-based combo could be one of the best choices?
Well, at least the data go in this direction. So we had this subgroup analysis from the Checkmate 227, and we have a similar outcome from the Checkmate 9LA. And as Shirish has shown, the data of the Keynote 407 in this group of squamous PD-L1 negatives are a bit limited. So it's a bit intriguing, but again, as mentioned, we have to be very, very cautious. We are talking about a subgroup analysis with all the pitfalls that we are facing here. But overall, I think if I would have such a patient, and if this patient would be in a good shape, this would be one of the patients where I would consider this new regimen. Good.
I have a consideration in that question. So Roy, in his exposition, didn't focus so much for the second-line immunotherapy, focusing exclusively on pembro use. Do you think that, but in our real life, for many patients, we yet use immunoagents in second line. So do you think that there are some important difference among different checkpoint inhibitor in second line? So among pembro, among nivo and atezolizumab, they are similar?
I think with regard of the data, the only negative try so far in second line has been presented for avelumab, potentially also related to the changing landscape of immunotherapies. But with regard of these three checkpoint inhibitors, I do not see any significant clinical differences between the agents.
Good. I don't see any other questions.
I would have a question to Shirish and also to Paul, because I need to capture this opportunity. So in particular, when we talk about this new opportunity of immunotherapies, one big question, and this has been captured also by Roy in his presentation, is the duration of treatment and the question of re-exposition of a checkpoint inhibitor. So Shirish and Paul, how long do you treat your patients with immunotherapy? Because in Germany, we have the problem, the trials have been conceptually designed for 2 years of immunotherapy, but we have a label of immunotherapy until disease progression or appearance of non-tolerable side effects. So we are a bit in the conflict between a real maintenance of the immunotherapy and a stop of treatment after 2 years.
So if I may start, it's of course a relevant question. It hospitalizes the patient and it has quite some impact. I think if we look at the data from the Keynote 10, where Roy and myself have done also some quite some long-term analyses, yeah, we know that also from Checkmate 151, I believe the stopping after 1 year is not enough. Then there's the biggest chance of recurrence, and 2 years seems to be a turning point. If you then have a patient in follow-up, the chances of having a disease control rate at the recurrence is about 70%, 70. So this is what I adhere to. My patients quite often say, "Oh, are we going to stop? I'm afraid. Can't we continue?" But I think here we must draw a line because of also the finances. We can't give these drugs forever, to my opinion.
Yeah, I would agree with Paul. I will only say that I have a discussion, and maybe I am not. I'm somewhat weak compared to Paul. So if my patients insist, there are some patients who are very happy that they don't have to keep coming for the treatment. But if there are patients who are really nervous, I have continued. So I've tailored it to the patient's desires, though I usually recommend stopping at 2 years if they have not had progression. I'll just mention 2 issues in this regard. I know we are probably short on time. One is, I can tell you during the pandemic, a lot of people were happy stopping at 2 years because then they didn't have to come. So there was definitely a change during the pandemic. The only other thing I'll mention is that in US, at least, I'm not sure in Italy and Germany, we have the every 6-week schedule approved for pembrolizumab. And I can tell you that particularly patients who are on every 3 weeks, when they were switched to every 6 weeks, again, personal experience, anecdotal, please view it with a high level of caution. I've seen a little bit of higher immune-related AEs. And I wondered if that is the similar experience. And I'm sort of not doing every 6-week schedule, even in the maintenance setting anymore, because I've sort of been spooked by the immune-related AEs I've seen with that schedule.
So may I do a comment?
Briefly.
In this moment, so we can draw the conclusion that 2 years of treatment can be considered a reasonable interval for continuing to suspend the treatment. But we have also the data of patients that have suspended the treatment because of adverse event, and they have a very good response after discontinuation of treatment. And we have experience of response lasting years with few cycles of immunotherapy. So I think that there are some contradictions, and we don't know exactly what is the right time for discontinuation of immunotherapy. I think that 2 years is a compromise that can be accepted.
Of course, it's a compromise, and I think it's mainly being on the safe side.
Yeah.
As we see, if we have more, and it was elegantly shown by the 2 speakers, if you have an adverse event on the IR, well, everybody has seen it. Sometimes it's for months under control. So it's really patient dependent. And that's why I think that 2 years will, for my feeling, is a little bit on the long side, but it's what we have in data. That's the only thing I can say.
Hey, my friend, it's time to move to the next session. Many thanks for your participation as presenter and for discussion. So the discussion is the soul of our conference. So it's very important. Many thanks. I see on the main room the other participants, the other friends and speaker for the next session. Hi Fabrice, hi Marina, and also the same to Ramalingam. Many thanks. Hi Suresh. Many thanks for your coming virtually in Milan. Good to see you, and I am honored to introduce Marina Garassino, the most important oncologist, Italian worker in US now, because he lives in Chicago. Marina, please.